Good evening, everyone. Welcome back to my IVF Fences and welcome back to one IVF webinar with us. I'm glad to be back with all of you. I do see that some of you have been here before, so I'm even more happy that you are able to come here and join us every now and then to find out a bit more, but also, as it's always most important, you are here for your questions and, of course, for some advice. And we do have a very special guest, and this is Dr. Mauricio Gómez. He is a gynecologist at Reproclinic, which is located in Barcelona. Dr. Gómez is with us once again, so I'm very happy that you are back with us, and I'm already looking forward to what you have prepared. Hope you had a busy Monday, I'm sure, but I hope you had a nice Monday so far. How is it going?
Yeah, fine. Ready to go.
Happy
Going
to
to
hear that. And of course, tonight, as you see, we will talk about low ovarian reserve, and Dr. Gomez has prepared 3 cases. So, of course, he will walk us through all those details, what has been done to get to that successful outcome, but also he will answer all of your questions right after the presentation. So, as always, don't hesitate. You just need to put the time, all the questions you need to type in the chat section, and Dr. Gomez will help you out. So, as always, don't hesitate, okay? This is your time to learn, and this is your time to get some answers as well. So, thanks so much. I will leave it here, and Dr. Gomez, ready to start with the presentation?
Okay, Caroline, thank you again for your gentle
Thank you so much.
introduction, as ever. It's a pleasure again to share with you the next hour with the aim of presenting 2 clinical cases, not 3 in this case, we're talking about 2 clinical case reports of patients with very low ovarian reserve that became successful in terms of ongoing pregnancy and newborn alive. It's time to pass from the theory to the practice, and these are nice examples to show you how it's possible, considering the scientific evidence, a small dosage of creativity, and a bit of luck, obviously, to get these patients' dream come true. Before anything, I'd like to remember that there is not any conflict of interest with any pharmaceutical or clinical device company. That's why you can consider my opinion unbiased. And let's talk about the first case report. We are talking about a 34-year-old patient without allergies or toxic habits, no family medical history of interest, and as personal medical history, she is presenting hypothyroidism treated with thyroxine and low D vitamins levels treated with D vitamin supplementation once a week. As a surgical history, presents an hysteroscopy 1 year ago to remove a partial uterine septum that after another control 2 months later shows normally. She shows regular menstrual cycles and she's never been pregnant. The last gynecological examination, including pap smear, was normal. She's married and her husband, 35 years old, is a healthy patient and he's not having child from previous relationships. They are coming to my office referring 3-year primary infertility. 2 previous IVF treatments in other centers were done. In both of them, high dosage of gonadotrophins were used into an antagonist cycle. The first one was cancelled before the collection after the answer of only 1 follicle. In the second one, antagonist cycle again, FSH plus LH combination, menopause 300 units, was used instead of RFSH. 2 follicles grew, and at the ovarian puncture day, only one egg was removed. But it was not fertilized. That's why they had an embryo to transfer. The results of the test requested showed us a normal spermiogram and an antimullerian hormone, as you can see, very low, 0.2 nanograms per milliliter. The rest of the test, including karyotypes, X fragile chromosome study, serologies, biochemistry, cells count, and thyroid and D vitamin function, were within the normal range. The gynecological ultrasound showed very low antral follicle count, in this case, 2 follicles, with normal uterus and endometrium. After studying all the results and considering that she didn't want to listen about donor eggs treatment at that moment, another IVF treatment with her own eggs was recommended and accepted by the patient. But considering 2 previous failed cycles, it was the moment to change the strategy of ovarian stimulation, obviously. It was the moment of being creative. That's why we offered to the patient the possibility of doing a modified natural cycle. After first day of menstruation, a gynecological ultrasound was done in order to see the basal situation of the ovaries. At the beginning of that cycle, we saw 2 antral follicles. A second ultrasound was done at the 7th day of the cycle, and the ultrasound showed us 1 follicle growing at the right ovary, its size 11 millimeters. In 2 days, we did an ultrasound again, and the follicle was 15 size. Just that moment, we added orgalutran, this is antagonist of GnRH, and menopur in order to decrease the risk of spontaneous ovulation and give some extra egg vitamin to regulate the growing and the maturation of this egg. After another 2 days, the follicle had increased, reaching 19 millimeter size. The endometrial line was really good, measuring 9 millimeters and 3 laminate view. And just at that moment, we decided to trigger dually with decapeptyl and ovitriol. The egg retrieval was done after 36 hours of the triggering, and a mature egg was collected and inseminated in laboratory by ICSI with 1 spermatozoon. Just that night, 400 milligrams dosage of vaginal progesterone was started and prescribed twice a day. Good news arrived the day after. We had embryo, and just from that moment, we decided to culture it during 5 days. During this period, the patient kept her treatment with progesterone, thyroxine, folic, and antioxidative diet supplementation. Just the 5 days, better news still arrived from the laboratory. A good 4AB quality blastocyst was ready to be transferred. The transfer was done with Cook catheter and ultrasound control. The view was optimal, and the embryo was placed just in the middle of the endometrium. The posterior catheter revision was okay. Post-transfer instructions were prescribed, and a blood pregnancy test was done 12 days after. The result of the beta HCG was 350, and posterior ultrasound 2 weeks later showed an intrauterine evolutive pregnancy. The pregnancy passed normally without any complication, and at the 40th week of pregnancy, it was a vaginal delivery of a 3 kilogram newborn named Juan. These key reports shows us clearly some important questions to be considered in very low ovarian responders. The first one, much doesn't mean better. It's important to think about a controlled ovarian hyperstimulation in order to achieve as many eggs as possible. But if you find, for example, in this case, not previous answer the first cycle with high dosage of hormones, you have to change your strategy. And the natural cycle in this case represents a non-stressful way to obtain, in some cases like this, one healthy embryo that became healthy newborn. Obviously, it's important to share with patients this philosophy, and they have to accept the high choices of not having egg or embryo. But at least the treatment is going to be less stressful, this is sure. And finally, the most important question you have to know in this case is related with the age of the patient. Remember, 34 years old. This history demonstrates that the main factor of good prognosis is her age. The AMH, anti-Mullerian, or the antral follicles count are only markers of quantity, not quality. That's why we recommend to go on with the ONEC in young patients less than 36, even though they had a very, very low reserve. This is the resume of the first case. After that, we are talking about the second case. And after this second case, we'll be able to attend the question and answers. The second case reports, obviously there are some differences. talks about a 42-year-old patient without allergies or toxic habits. There was not family medical history of interest and not personal relevant medical history. She shows regular menstrual cycles, and the last gynecological examination, including pap smear and mammography, was normal. She is married to, and her husband, 49 years old, is a healthy patient. He's having one daughter from previous relationship. In this case, the obstetrical clinical history was interesting. She's been twice pregnant. First of one, she had to do a voluntary interruption of the pregnancy at the 14th week after being diagnosed of Edwards syndrome. The second one, a twin pregnancy, finished in abortion at 12th week. A chromosomal study of one of these embryo was diagnosed of Patau syndrome. This is a 13 chromosome trisomy. All pregnancies at the 40s were spontaneous. The results of the test requested showed us a normal spermiogram and DNA double-chain sperm fragmentation and normal, and an antimullerian hormone very, very low, as you can see. This double-chain sperm fragmentation, was asked related with the age of the husband in this case. In our center, patients older than 40, we strongly recommend this test in order to have more information about the quality of the sperm. The rest of the tests of the patient, including karyotypes, serologies, biochemistry, cell counts, thyroid, and D vitamin function, were within the normal range in this case. The gynecological ultrasound showed extremely low follicle count, numbering in this case 1 follicle, with normal uterus and endometrium. They are coming to my office referring recurrent pregnancy loss, and in both cases, the cause was related with chromosomal disorders, as I've told you. They didn't want at that moment to talk about egg donation. That's why an IVF treatment, after explaining the low choices of success, with preimplantation genetic testing for aneuploidies was offered. After analyzing all the results and considering the very low ovarian reserve, it was the moment of being creative again. We started with a combined treatment with letrozole, 5 milligrams a day in 2 doses, and 150 international units of menopause. The idea was to stimulate the recruitment from 2 different action mechanisms, following previous described protocol. The answer was surprisingly good. In fact, 3 follicles grew, and ovarian triggering was done with Ovitril and Decapeptyl, dual triggering. At this first time, 3 eggs were collected, of which 2 of them were fecundated. Finally, only 1 embryo arrived at the blastocyst stage, and obviously it was biopsied and frozen. Just 4 days after this egg collection, an ultrasound was done. We saw 2 antral follicles of 6 and 8 millimeters and decided to start the day after another ovarian stimulation with 225 international units of menopause. The idea was to accumulate more embryos at the same cycle, considering the few options of having a euploid normal embryo in a 42-year-old patient with a clinical history, and the patient agreed. After 5 days of stimulation, first ultrasound control was done. 2 follicles had grown, 1 in each ovary, and after another 2 controls, they were ready to be collected. The dual triggering was done again in the same way, and 2 eggs were collected. All of them were fecundated. Unfortunately, one of them became blastocyst. That's why it was biopsied too and frozen. As you can see, an antagonist protocol in all of these cases was done. After 3 weeks, the results of the PGT, the biopsy, were reported. The blastocyst biopsy at the first part of the cycle was aneuploid. The second one, retrieved after the luteal phase stimulation, was euploid. That means chromosomically normal. It was a great success. The news were really fascinating. Just at the moment, the choices of having success were really high. The most difficult step was done. We decided to do an extra study of the endometrial receptivity that showed us a 24 hours moved implantation window, pre-receptive. And according with this result, we started at the beginning of the next cycle a substituted cycle with 6 milligrams daily dose of oral estrogens. Just when the endometrial line reached a size of 8 millimeters, through laminar, we started progesterone vaginal treatment. And after 6 days, 1 day more than usual considering this result of the ERA test, we transferred this euploid embryo with Lavotec catheter and ultrasound guide without any incidents. After 2 uncertain and stressful waiting weeks, that pregnancy and test was positive. And after that, the pregnancy was really good, and the patient finally delivered a healthy baby by programmed cesarean section at 40 weeks of pregnancy, just on term. In contrast with the first case, this patient had an extra factor that added more difficulty to achieve pregnancy, more than 40 years old. It's important, this graphic, to show you that it's so far demonstrated that the average number of eggs retrieved required to get a healthy euploid embryo in a 42-year-old patient is more than 15, more or less, to be at this level of the graphic. In our case, we only were able to collect 5 between 2 procedures at the same cycle, do a STEAM protocol. That's why, considering this theoretical 15 eggs required, we were really lucky. If you pay attention, in first case patient, considering her 34 years old, and considering the statistics, we should have collected between 3 or 4 eggs to assure 1 healthy embryo. We only get 1, but at the 34, we didn't recommend the genetic study. We were lucky in both cases, but sometimes this luck deserves to be sought. And the main take-home messages for this second case is that the decision of trying a non-conventional ovarian stimulation protocol is taken considering the very low ovarian reserve. As I told you before, much doses of medication doesn't mean better. The idea of accumulate embryo was obvious in order to get as many embryos to be evaluated as possible. And the decision of offering PGTA is strongly recommended from the 38 years old and older. Obviously, it's very important to share with the patients this philosophy, and they have to accept the high choices of not having egg or embryo. In this case, we are talking about the successful cases, but as you can imagine, not all, unfortunately, have the same luck. And if we are so lucky to have 1 GOF embryo, another interesting question, it's interesting to do an extra study of the endometrial receptivity in order to get ready the best endometrium for the best embryo. That's why we offered to do this ERA test before the transfer. And here they are 2 nice cases before the questions. And remember that we are here in Barcelona, in Reproclinic, for attend your consultants. Finish.
Thank you so much, Dr. Gómez, for presenting those 2 very different but also very interesting cases. Thank you for explaining what was done from the very first appointment to the final outcome, of course. And yes, you are right. It's time to start with the questions. As you can see, plenty of questions are right here. So let's get to them, okay? And remember, this is your time. If there's anything you would like to ask, you can do it now. And let's begin, okay? There are a few questions. Let's start with the first one, a bit of a detailed one right here. SCFA is a normal on case 2, but how about function regarding decondensation, early or normal?
I don't exactly understand the concept of the condensation in this case. Defreeze means, I don't know. No.
Okay, if you can just follow up and give us some more details exactly what you mean so that we can help you out, okay?
Because
Because
yes, yes. If
it's of
you
course very,
help me in order to understand the right question, to
of course, that's not a problem at
get
all.
the right answer.
I think someone is typing. It's possible that Derek is trying to clarify. So we'll go to the next question and we will go back to the previous
Yes,
one when we have some more clarence here.
I can
Okay,
imagine,
clarity.
but I would like to know sure exactly the concept.
Sure, no problem at all. Okay, let's have a look. It's a bit of a longer question, the next one. So let's see. I'm 32, did 3 IVF cycles due to my husband azoospermia. The first 2 cycles resulted in four top quality embryos that never implanted. I was on gonal F 225. We then moved clinics and repeated surgical sperm retrieval and did higher stim cycle gonal F 300 menopause 75. We got more eggs, but only 2 poor quality fragmented blastocysts on day 5 that ended with chemical pregnancy. In your opinion, is this a problem with sperm or was the new protocol unsuitable for me? Thank you for sharing. Thank you for your question.
It's possible that obviously as these questions are right now with the best of intention, but some information maybe I'm not able to have. That's why it's difficult to give the best advice. But for example, considering the age, the theoretical quality of this egg might be good. I think she's talking about a husband azoospermia. That's why I would like to know if finally I can understand that the treatment was done with sperm donor, I can imagine. And attending the quality of embryos, it's strange, obviously, not to having success. When we are talking about implantation failure, and recurrent in this case, it's important to take in consideration the possibility of do an extra study for these embryos in order to assure that are healthy, because one question is the information at the laboratory just the day of the transfer, but another question is be sure that this internal quality of this embryo is right, because the main cause of recurrent implantation failure is the quality, the internal quality, the presence of chromosomal disorder. That's why, considering the 3 attempts without success, it should be interesting if she's able to try again, obviously, doing this PGT for aneuploidies with her embryos. And I can imagine with the sperm donor, but theoretically the quality should be good, but if it's not previously tested, it's time to change in order to deep this study for these embryos.
Okay, thank you. Just one more thing. As you saw, Monica has added something, not sperm donor. We use surgically aspired sperm, right? Just to clarify.
Okay. These are interesting questions. Theoretically, if it's possible to collect this spermatozoa with this treatment, the question is to be sure that this spermatozoa has the same quality of a normal spermatozoa from a normal ejaculation. Sometimes we have found that the internal quality of this spermatozoa is not the same, and that's why obviously if it's been possible to get this sperm, this is a very good news for this couple. But obviously, I think more studies would be needed to assure that this quality of the embryo is really good, and not only by the external view at the 5th day of development. It's important to do this biopsy to assure that in this case, its chromosomal charge, its karyotype is healthy, it's good. Mm-hmm.
All right, thank you from Monica for you as well, right here. And let's go back to the previous question, okay, from Derek. So this is the case number 2 that you have talked about. So the question is, fragmentation was normal, but how about the condensation rates times? Are you able to help us with that?
Fragmentation of the sperm sample, I can imagine. Of the sperm sample, I can imagine, and the RFA means the follicle antral recurrent, I can imagine too. Can you go back to the first question, please?
Sure, yeah, sorry, right here.
Yes.
Sperm, yeah. Derek has confirmed, of course. Sperm fragmentation.
Okay. Theoretically, depending obviously of the age of the patient, we are talking about a low ovarian reserve, as I can imagine. No? If we talk about is antral follicles count, 2x. If the patient is younger than 35, 36 years old, as I told you before, the most important question is the quality of this possible egg. This is sure that we are not going to retrieve so many eggs, considering the low ovarian reserve. But theoretically, if we are able to stimulate by a natural cycle or with small doses of medication, 1 or 2 follicles, and we are able to retrieve one healthy, one mature egg, if the sperm sample is good, we are talking about an easy treatment. Theoretically, for a biologist, it's not difficult to take one healthy and mobile spermatozoa to fecundate this egg. This is a choice of really having a healthy embryo with some choices of success. Obviously, the number is too low that all the information must be given, no? In order for the patients to accept that there are really choices of not having embryos at the day of the transfer. But if we're talking about having a possibility related with the quality, related with the age, you should try in this case. Mm-hmm. Related with the rate and the times, I don't understand really exactly what it means, but the times when we talk about a patient, a younger patient, we recommend to do transfer obviously in fresh. If this sperm sample is previous frozen for any problem, once the freeze, the transfer can be done obviously after 5 days after 5 days of fixing. It's not a problem.
Thanks so much, of course. And if there's anything else you would like to add, of course, go ahead, okay? But I hope that it has been clear for you. I think so. Yes, right here. Thanks so much indeed. Okay, let's have a look. There are 2 parts of the question, so I will read both, and then we will go back to the previous one, okay? So I'm 45. Our ultrasound last month showed 2 follicles. I have not been pregnant in the last 18 months, had 2 miscarriages previously. An indication for egg retrieval, I have subserosal and intramural fibroids. And the second part, I would rather have IVF with my own eggs if possible. Plan B is to do IVF with egg donation on beginning next year. I still don't know about how many eggs to get for successful pregnancy and to have 2 children. What's your advice in the number of eggs? And now I will show you the first one. Thank you.
Yes. Connected with the report case of the second patient I have shown, no? It could be a similar case. First of all, the statistics say that it would be needed more than 20 eggs to have one healthy euploid embryo. But this is only statistics. For example, in our case, from 5 eggs, we had one healthy embryo. The problem is that every year from this 40, the prognosis is decreasing dramatically. That's why 45 years old, the statistics are really, really bad. I'm afraid that in my experience, patients older than 43, 44 years old, the recommendation from the beginning is thinking about donor eggs. Obviously, respecting the trying at least once, no, with her own eggs. In this case, the problem is that added not to this age that it's impossible to change, obviously, 45 years old, we are talking about a low ovarian reserve. That's why many cycles in order to accumulate eggs and embryos would be needed to have some healthy embryo and without any certainness. That's why it's very difficult to be optimist in this case, really. Obviously, in order to try, if we try once, it's possible to collect 1 or 2 eggs, but you have to recognize that it's a very large race obstacle to achieve one healthy embryo, and with many possibilities of stopping just at the way before arriving. No, it's a complicated case for 2 things. No, the age 45 is not the same than 42, the age of my patient. First of all, the ovarian reserve is more or less the same, but insist 3 years are very important in this case. Considering the fibroids, it's important to know the size of the fibroid, and considering this intramural, subserosal, they are not important, but intramural, depending the location inside the uterus, it's not the same an intramural fibroid near the endometrium, this internal surface, or just a bit longer, no, or so far. it should be interesting to have more information about these fibroids, because if finally this patient is deciding to do the donor egg treatment, in this case, obviously the quality of the embryo should be assured, but the receptivity of this endometrium is strongly related with the location and the size of these fibroids. That is why it's important to look exactly if this patient wants to become pregnant, to be sure that the internal surface of the endometrium is right, is healthy.
Thanks so much for a thorough answer to yet another question. There are more questions coming up. Let's have a look. Sarah, she is 32, and here's the next part. I have premature ovarian insufficiency with an AMH of 0.7 and completed cycle on gonal F 350, which resulted in 2 frozen eggs. I repeated a second cycle on gonal F 350, which ended in a cancellation due to only 1 follicle maturing. Do you have any advice for next steps for a patient with premature ovarian insufficiency?
Okay, how old is this patient?
32.
32 years old, yes. This case, for example, is similar as the first case I have presented. In this case, obviously the number of eggs is going to be low, and this is the right example to show us how much dosage of medication doesn't mean more eggs. That's why in this case it could be interesting to change of strategy and thinking about doing or a natural cycle or a minimal stimulation cycle, considering it's only to grow 1, maybe 2 follicles, but theoretically we don't need more follicles to have one healthy embryo. And the age, it's possible that could offer a mature egg, and after the in vitro fecundation, a healthy embryo. Obviously, it's time to change of strategy. There is no sense to repeat high dosage of gonal to have the same result. And we have seen sometimes that most dosage of medication can be stressful for the ovaries and can decrease the quality of this egg. That's why my recommendation would be maybe try again for the last time, maybe, I don't know, depending obviously of the patient, the optimism of the patient, but changing this strategy and talking about stimulate with very, very less dosage of medication, or maybe doing this natural cycle. And obviously, if one follicle is growing, go on behind this.
So much indeed for yet another advice here. And let me go to a question from Eliana. It's a follow-up. Before that, there's a thank you from Sarah for you. It's regarding the patient who is 45 and had fibroids. So she has provided some more details. Let's have a look. In case there is more time to follow up, how does the fibroids impact IVF with egg donation? Scan set 2019 and set 2021. For 2.4, 2.6, 2.3 centimeters intramural in the anterior right myometrium. And as you can see, all the details you can advise, I'm sure.
Okay. Theoretically, related with the size of these fibroids, there's no reason to worry about the prognosis, the bad prognosis. Theoretically, this is a normal size. It's not needed, it's not recommended surgery before the transfer. This is an important question. It should be interesting to have more information about not only the location at the uterus of these myometrial fibroids. It should be more interesting to know about the distance from the endometrium, because when we talk about intramural fibroids, there are different types. 3, 4, 5, depending the length, the distance of the endometrium. It's not the same having one intramural fibroid type 3 or type 5. It's a very, very, very strict concept of the situation. But theoretically, if they are really as this patient is showing at this picture, theoretically there is not any problem to do an egg donor treatment and transferring a good embryo with good choices of success. The indication of surgery is done when the size is more than 4, 5, 6 centimeters. There is not consensus, but theoretically over than 5, 6 is recommended when we talk about intramural. And obviously, if they are contacting also contacting the endometrium or submucous, they must be removed after the in vitro treatment with donor or with your own eggs.
Thanks so much indeed, of course, for a follow-up details and your help. I do believe it has been helpful for you, Eliana, so thanks a lot. And let's have a look, okay? There will be some more details right here from... first let me go to this question. Why did you do, when it comes to the case, right? I believe it was the second case. Why did you do double trigger and why did you give oraglalutran, in the luteal phase stimulation?
This is a very good question. Theoretically, in this luteal phase stimulation, considering there are high levels of progesterone that can decrease the risk of spontaneous ovulation, when we find a follicle, one or two, because we're talking about obviously ovarian answers usually, just the last days before the ovarian retrieve, the ovarian punction, the egg retrieval, we like to add when we have a follicle maybe bigger than in a follicular phase, more than 15, 16 millimeters, in order to be sure there is not an extra risk of spontaneous ovulation. And I like to do this double trigger because it's a philosophy. There are several studies that show us with two ways of stimulate the final maturation of these eggs, with this agonist of generate and with this orbitrel, we have better results related with the quality of the egg and the maturity and the health of this embryo. Obviously, it's difficult to assure, but there's not really any problem to add some extra medication to do this ovarian discharge, this triggering. And in my experience, really, I have found very good results in surprisingly cases like this, like these two cases. And I'm not able to know surely if it's been due to this dual triggering, but considering the evidence, the scientific evidence, first of all, I am not damaging any patient with this strategy, and the results are being interesting in my case.
Thanks so much for a definitely interesting question and your help. And now might be our final question. So, of course, if you have more, go ahead, type those in, and let's have a look as there are more details here. And right here. First time attempting IVF in January, I'll be 40 then, had IUI in 2016, AMH of 2.63, first time successful pregnancy. In 2021, no positive pregnancy. AMH was 2.1 in January 2022, and only 0.8 in August 2021. Antral follicle count is around 8-10 on most cycles. Should I push clinic to go for low stimulation or just go with the usual level of stims? I want to try with my own eggs, donor sperm, same donor as 2016 pregnancy.
Okay, with 40 years old. Mm-hmm. And related with these results, in this case, normal, low, normal anti-mullerian hormone, and between 8 and 10. I would like to know exactly how many eggs were collected, but for example, in this case, for example, if we have got a normal or a bit inferior ovarian reserve, and considering she's 40 years old, in this case, it should be interesting to have more eggs in order to try to have more embryos, because our recommendation, for example, is doing this biopsy for the pre-implantational genetical testing, considering the choices, that the risk of aneuploidy. That's why in these cases, it's interesting to have, obviously, more eggs. That's why it's possible that I would try with a medium but higher dosage of gonadotrophins, because, as I told you before, much doesn't mean better, but in some cases like this, for example, it should be interesting to have a good number of eggs, considering not from the beginning they are going to fall during the way. If obviously she's doing 2 previous treatment with high dosage of medication without success, we could try a soft way of stimulation, but always with a bit of dosage. I think doing a natural cycle, if there is possibility of having more eggs, it's a bit risky. I recommend the natural cycle when the ovarian reserve is really very, very, very low. And I'm sure that not giving more gonadotropins, I'm going to get more eggs. But theoretically, in this case, it's question of trying again and hope, and wait for finally having one healthy embryo. Because theoretically, with 40 years old, the statistics is not to be completely pessimist. She could try again. Maybe it should be interesting to know exactly the combination of the hormone, FSH, LH, what kind of ovarian stimulation exactly she did in order to change some questions, the antagonist cycle, when it was started the antagonist, when dual triggering or simple triggering. There are many, many factors of the stimulation that are not reflected in this case. It's an interesting case to analyze, but with many, many factors that I am not able to control. But for the main question, I would try again with her own eggs, but not in a natural cycle idea philosophy, trying to stimulate with a bit more doses than I have explained it in these previous cases.
All right. Thanks so much for yet another advice. And let me have a look. Of course, here there's another question from Eliana. In case of scan showing trace of free fluid in the POD, do you recommend further investigation before starting IVF?
Let me see, POD, because
Yeah,
sometimes
sure. I don't know as well, I'm afraid. Yeah, here it is.
Douglas, no?
It's right here.
Douglas, yes.
Found trace of free on pouch of the.
Exactly.
Okay, Douglas. Okay.
Okay. In this case, could you show me the previous question?
Yeah, sure. Sorry.
Okay. It would be interesting to know exactly when it's done, when it's been done, this scan, this ultrasound, because, for example, if you see fluid during the ovarian stimulation, sometimes it's related with the same process of stimulation. If you see fluid, organized fluid, between the ovary and the uterus, it's very important to be sure that it's not an hydrosalpinx, for example. Sometimes we find that in this fallopian tube, there is some amount of liquid that can be dangerous or can damage the embryo implantation. That's why if we have the suspect of having this liquid inside the fallopian tube, it's very important to know sure, because in these cases it's recommended surgery, laparoscopy, before transfer. If this liquid is in Douglas and her gynecologist is sure that it's not related with liquid inside the fallopian tube, there is no reason to worry about it.
Again, thanks so much indeed. And okay, thanks so much indeed. Sorry, let's have a look. One more question, a bit longer question as well. I'm 42, trying to conceive for 6 years, AMH 4.2 picomoles. I have low ovarian reserve, male factor issues with DNA fragmentation. My husband is 39. Due to male factor, we have used X each time. Normally produce 3-4 eggs each cycle, of which produce 1 5-day blastocyst. So far had 2 fresh transfers with failed attempts, then did 3 batch cycling and did frozen embryo transfer. From the batch collection transferred 2 blastocysts and had chemical pregnancy. Still have 2 blastocysts left in the freezer. Scared to lose those 2 if implantation failure, and these are lower quality blastocysts. We did immunology tests for NK cells, which show slightly increased, but no big problem. I don't want to take steroids or extra infusions if not proven to make big difference. Should I go ahead with frozen embryo transfer to blastocysts left?
I would like to confirm that in this case, when they did 3 batch cycling, I cannot exactly understand this concept. Excuse me. We're talking about a treatment with her own eggs.
Yes, I believe so.
Okay. Here, this is a good question. The hypothesis, no, the main probably cause why this patient has not become pregnant with ongoing pregnancy with success may be related with the internal quality of these embryos. Exactly. Thank you. Thank you very much. The main cause, as I told you before, of implantation failure or this biochemical miscarriage is related with this problem of the embryo. If this PGT, that for us is very, very important in order to avoid, no, obviously, heavy situation, no, and repetitive failures, in order to be sure, no, that these embryos are healthy, are really healthy, would be analyze these embryos. But the problem is that if they are frozen, and analyze this embryo represents defreeze the embryos, biopsy them in order to have the results, and after that, freeze again and defreeze another time in order to transfer. If they are external, good quality embryos, obviously she could try again. The main hypothesis is that the problem related with the embryo factor. The immunological factor is very controversial, and I'm agreed really with this patient in the fact that the immunological theory to justify this implantation failure is very, very difficult to assure. And we have to know that this treatment recommended when there is a spike like corticoids, antibodies, can be dangerous for the patient. That's why it's important to be sure that there's not any more frequent problem before thinking about the immunological problem. That's why with 42 years old, a patient that is trying with a normal, suboptimal ovarian response, the most important thing is to do the study of these embryos before transferring. The problem is when this treatment is done and this embryo has been frozen, we have not the possibility, or it's very difficult to biopsy just at this moment. That's why I should try, obviously, because it's possible that in these two embryos, after the transfer, she's becoming pregnant. Theoretically, if these are the last two in this case, theoretically, their quality is not the best. Theoretically, it's the worst of all of them. But there is not a direct relationship between the external quality, the microscope quality of this embryo, and the internal quality. It's possible, I have found in my practical, that sometimes after 2 or 3 attempts with theoretically better embryos than the last one, the patient has not become pregnant, and after the transfer of the last blastocyst, theoretically the worst, the patient has become pregnant. That's why I would try. Maybe sometimes we offer an empiric treatment in order to, I don't know, to cover all these hypotheses, but always with a low dosage of medication like aspirin. If I try with corticoids, we are always working with small doses of prednisone or methylprednisolone. Sometimes heparin, but for example, if I give heparin, I would like to know sure if there is any thrombophilia, if there is not any vein problem or vascular demonstrated problem, there is no sense to add more medications, increasing the risk for the patient. That's why it's difficult to do the best advice. Strong evidences for thinking about an immunological disorders can be taken, but always after being sure that the embryos are healthy, are internally healthy. And it is the main problem, that the usual culture in many centers is not doing this study in these embryos before transferring them. And when they are frozen, the situation is more complicated.
All right. Thank you. I know that it's always difficult to answer if we have this kind of, case where there's a lots of details that you definitely need to look at. So I just want to remind everyone that, of course, if you wish to get some more details, it is possible. Just contact Reproclinic team, and I'm sure they will be able to help you even more. So thank you so much. But Belinda Eliana, already would like to thank you, and Belinda as well. Thank you so much for
You're
your honest
welcome, really.
answer, indeed. All right. Again, there is another question, 3 parts. So let me go one by one. So I'm 42, tried 2 attempts. First one produced 2 eggs, only didn't fertilized. Second attempt got 4 eggs, 2 fertilized, were transferred on day 2, but failed to implant, and follicle count is 8.10. Testosterone flare protocol was used the second time. Doctor said I could try again and will say with the same type of chances of conceiving. Is it worth another try with my own eggs or go for donor eggs?
Could you come back? Yes,
Sure,
yeah.
right here.
Oh, there are interesting cases, really. The same comment related with this case. The main problem, no, with that is that with 42 years old and with a very low viral reserve in this case, we have got 2 difficulties, no? That related with the quality of these eggs. That, as I told you before, theoretically attending the statistics, between 10 and 50 eggs would be needed to obtain at least one healthy euploid embryo, and that represents that this patient should do between 4 and 5 ovarian stimulation cycles, attending the statistics. Obviously, if she tried again with her own, as I told you before, the PGT, the pre-implantational genetical testing, would be strongly recommended to be sure that she's able to have this healthy embryo, because if not, there's no sense to transfer anything. And if she tried again, she really has to know that the choices are obviously low. I know it's difficult to accept for a patient that's going through the donor egg treatment. I have to tell for all these patients that before taking the decision, in these cases, there are no reasons to hurry about the choices, because until the 50 years old, the choices, considering the quality of the endometrium, that is not damaging with the age, no? Obviously, if there are no thyroids at the same, obviously it's important for these patients to be mothered, obviously, as soon as possible, no? Considering all the process of the pregnancy. But after 2 attempts with a low ovarian answer, and obviously without more information, if she wanted to do again another treatment with her own eggs, she should ask for her doctor to do the study of this embryo before transferring them. There is no sense to transfer 1 or 2 embryos at the second day without having more information about them, because the more possibilities, the hypothesis more probably is that these embryos are not going to arrive at the 5 days of development. And for me, it's better to tell, it's difficult, but it's better to tell to a patient, listen, sweetie, we have not embryos to transfer. It's a difficult information to do, but we have tried to culture this embryo until the 5 days of development in order to have more information. And if they are not arriving, it's sure that they are not going to arrive to give a pregnancy. That transferring at the second day, and let's see if we have a luck. Theoretically, if she's thinking about doing another treatment, obviously she has to arrive until the end, but knowing that choices are really, really low in this case. And obviously, thinking about the donor eggs is not a bad idea.
All right. Again, thank you so much for your question. I do believe that it was, again, helpful. Of course, those are definitely not easy questions and answers, but thanks so much indeed. And let's have a look. One more question is right here from Penny. In February 2021, I had scans which showed high ovarian reserve. I was 43, but I was told I had reserve of a woman in late 30s. In last 6 months, my periods are still regular, but shorter, 2-3 days. Could this be that I am no longer ovulating and my ovarian reserve has diminished quicker than expected?
Yes, with the aging, the cycles start to be shorter, and the reason is why, depending the number of the eggs, the rhythm of growing is faster, and that's why the quality. This is another indirect sign of the quality is starting to decrease, because this accelerated follicular phase means that the egg hasn't had time to maturate adequately, and this is the beginning of obviously the decadence, no? And the losing of quality of this, an external sign of these eggs. I have found some patients like this that with 42, 43, 44, the number of eggs is really much higher than expected for her age. But it's not correct to compare these patients with a younger patient, because you are giving some expectations that are not certain for these patients. The age, we cannot change the age, and the quality is strongly related with this age. The number, it's important, but finally, in a 43 years old patient, the choices of having one healthy embryo are more difficult. Theoretically, if the reserve is good in this case, it could be tried a cycle with medium or maybe high, in this case, dosage of ovarian stimulation, considering that it's possible to collect an interesting number, maybe, I don't know, 10, 15, no, if this comparison with a 30 years old patient. And if the point of starting is about 15x, attending this graphical no before, it's possible we had luck and we were able to find one healthy euploid embryo. That's why it would be possible to try at least once, but considering from all this good number of follicles, sure, they are going to arrive a few embryos, and I wish and hoping that it would be very difficult to find finally one euploid embryo.
Much appreciated. And of course, there are comments for you right here, okay? So thank you so much for an honest answer. Really appreciated. So thank you indeed. And let me just go ahead to one question right here. When doing egg donation, how many eggs for 2 pregnancies should be transferred, right? 2 at the time, 2 at the same time? Embryos, I guess, right? Sorry.
Yes. When doing a donation, first of all, if patients really have this illusion of having 2 children at the same time, or they prefer obviously to assure a good number of embryos, you have to consider that the theoretical quality of this donor is good, but the same conclusion. This is like a race obstacle. If the point of starting is about, for example, 8 mature eggs from a donor of eggs, sure, they are not going to arrive these 8 eggs until 8 quality embryos, leaving the quality of these eggs. That's why if a patient wants to have more choices for a future in order to have a bigger family, I recommend at least 15 eggs to have at least between 2, 3, 4 healthy blastocysts. And if you transfer at the same time 2 embryos, you have to consider, obviously, you have maybe more choices, but the difference is small, smaller than you can imagine. And obviously, you are adding an extra risk of becoming pregnant of twin pregnancy. And obviously, when the pregnancy is going right, obviously the ideal family, the ideal view, in the future after 9 months of having all the family done with only one treatment at the first time, it's very, very exciting. But I have to recognize, as a gynecologist, that I don't know, 6 months before I still was doing deliverings and cesarean sections, pregnancies, the risk of a twin pregnancy is higher than you can imagine. Most important, and over the 40 years old, when we talk about the donor eggs, and the most important risk is related with the prematurity. If a twin pregnancy patient has this problem, for example, start her delivering process at the 6th or at the 7th month of pregnancy, you have to consider that the risk for the prognosis for these babies that can born 2 or 3 months before than usual is very high. That's why very important to know. Just at the moment you decide to transfer 2 embryos, this at risk from a twin pregnancy are not low. It's an important rate of prematurity delivery in this case.
Of course, thanks so much.
My recommendation, doing one step by step, one after one,
Of course. Thank you so much for the clarification once more. Okay, let's have a look. We have some more details here from Monica. Our previous patient's question was here, right? We tend to get early blastocysts on day 5. What we transfer fresh? Is it possible to PGTA test them?
Yes, this is a good question. When biologists do the biopsy for this embryo, first question, it's important to know, we recommend to culture these embryos until the 5 days of development. Why this? Because these embryos at this moment are stronger. They have more than 200 cells, between 100 and 200 cells, and for them, biopsy them at that moment doesn't represent a risk for its structure. After this biopsy, these cells obviously are studied in a genetical department in order to be sure that they are healthy and nucleate. But this process, until having this report and this information, is about 2 or 3 weeks. That's why always when this biopsy is done for this blastocyst, all the blastocysts must be frozen, waiting for the result. And really, the fact of freezing embryos, considering the actual technical, is not really complicated for us. It's not damaging the quality of these embryos. And the same comment for the biopsy. We have found that the pregnancy rates after a transfer of an embryo previously biopsied and frozen, the pregnancy rates are the same that if we transfer just in fresh. And the most important thing, with this biopsy, we are sure to know which of them are healthy and duplicate. And we are going to be sure which embryos we are not going to transfer in order to avoid, obviously, recurrent implantation failure or recurrent miscarriage. The rates of successful and ongoing pregnancy are going to increase considerably, dramatically, as you can imagine.
All right, and Monica has one more. Okay, is getting early blastocysts on day 5 indication that an embryo is growing too slow and is not likely to become viable pregnancy?
This is a very good question because actually the laboratories with very sophisticated programs of bioinformatics and artificial intelligence are trying to understand with this process of the growing of the embryo, are going to understand if these embryos are healthy, are euploid, without doing this biopsy. This growing process of these embryos, controlled with these time-lapse structures, and culture media, every time are doing and are giving us a more exact precision of if these embryos are healthy or not. But the precision is not 100% as the embryo biopsy. It's possible that after 2, 3, 4 years, because this is very researching interest question, biologists are able to know sure, depending on the growing of this embryo, if it's healthy or not. But actually, the sensibility is not 100%. They are talking about 60, 70% related with the embryo biopsy. That's why if you want to be sure about the chromosomal healthy of this embryo, a biopsy to do this study is needed in this case.
Understood. Again, thank you so much for your questions, Monica. I believe it has been useful, all the answers. And now, possibly our final question for tonight. So let's have a look. I'm 34 with AMH of 3.0 picomoles. Last scan showed only one follicle. What treatment would you recommend I should start? Previous ectopic and miscarriage.
Yes, obviously this is a bad fortune, a bad luck case in this case. This is a similar case of the first one case report I have introduced. A young patient with a low ovarian reserve. with obviously an ultrasound that shows only one follicle. In this case, for example, attending the first patient, I would recommend to be creative. No? I would be creative, and I would recommend to this patient to think about doing a natural cycle without stimulation from the beginning, in order to wait and to see how it's growing if she's regular menstrual cycle, no? Attending the normal growing at least of one follicle of this cycle, and just if it's growing over 14 millimeters, adding a bit of dosage of the menopur, 150, with added organotran in order to decrease the risk of spontaneous ovulation. And just when this follicle is arriving at the 19, 20 millimeters, do this dual triggering in order to hope to collect this one egg. And let's see, because related with this age, we have reason to be, at least we have a small dosage of optimism before thinking about the donor eggs. Obviously that with 34 years old, it will always be the time to decide this.
Of course. Thank you so much indeed for yet another question, and of course for your help and assistance. As I've mentioned, that has been our final question. So thank you everyone, each and everyone here for joining, for staying with us, and of course for your questions. I hope that it has been useful. I do believe so. Dr. Gómez, thank you so much for joining us tonight, for your time as well. And it was really great to have you here. I do hope that you also have enjoyed this and feel that you were able to help as well. Yeah, is there anything else you would like to add?
Okay, thank you very much, and see you in the next webinar, sure.
Yes, looking forward to the next webinar with you. As you can see, there are plenty of things coming up your way, of course. So thank you so much indeed, everyone. Remember, it has been recorded, so you will have a chance to watch this again if you missed any parts. You will be able to find this on my Abbey Offenses, and of course, I do hope to see you back here. Dr. Gómez, thank you so much. Have a good evening, and see you soon, I
Bye-bye.
hope. And of course, remember, we will be back here tomorrow at 7 p.m. UK time. So I hope you will have more questions and you will be able to join us. Thanks so much. Bye.